What's up, everybody? I am live. I'm going to do what I always do. Before I bring my guest on today, I'm going to make sure I am live so I don't waste valuable time with the two smart guys that I have on with me. I had a buddy of mine reach out a couple weeks ago and say, hey, I think we've got a good topic, and me and a buddy of mine have had some good conversations. Let's do a video about this. And it's about Corona headlines and the data they're in. I said, sure. And they're way busier than I am. So getting their schedules together was a little difficult, but we're finally doing it. I'm going to read you a couple quick bios of who I got coming on, and then I'll bring them up. So they're sitting here in the green room ready to come on. But Eric Buchanan is a disability attorney friend of mine. And if you want to know more about his bio, you can go to buchanandisability.com and read his bio. But Eric graduated from Washington and Lee University School of Law, Magna cum laude. In the top 10% of his class before law school, he graduated from VMI and served as an officer in the U.S. Navy from 1989 to 1994, where he served as a naval aviator, pilot in command, and mission commander of a PC-3, and I'm going to get this wrong, Orion sub-Honey aircraft. And I need to increase my font size. I should have brought my glasses in here. Among other positions, Eric served as a squadron's legal officer, for which he was awarded a Navy Achievement Medal. Also is his friend, and he said I didn't have to call him doctor, but I'm going to start off calling him doctor, and then later he can release me from that obligation. Jimmy LaMance. He's received his PhD from the University of Colorado Aerospace Engineering Sciences program in 1994, where he studied global positioning systems and remote sensing. He has worked extensively in the GPS research, design, integration, and test. He has developed GPS technology for use in cellular handsets, aircrafts, spacecraft, rockets, automobiles, and other location and tracking systems. His work included GPS receiver design, software, hardware development, system simulation and analysis, error analysis, receiver system integration and test, and GPS. And it goes on and on. Plus, here's the big thing. He's a scientist, and as Eric put it, he's a data geek. He likes data. He likes the numbers. He likes digging into it. And if I'm wrong, they'll both tell me. It's a lot of reading. It's the most reading I've done on a show like that. So I'm going to bring them on now, and they can tell me if I have messed up. What's up, Eric Buchanan?
How are you, Clint? Good to see you.
There he is, Dr. LaMance. How are you, sir?
I'm good, Clint. Why don't you call me Jimmy?
Yeah. Thank you. He's released me from the obligation.
I reserve the right to put it back, though.
Yeah, depending on how much of a butthead I am in this interview. I get it. I will say this, Eric. I was reading part of your bio, and it's, I could have kept going. Both of y'all have a very extensive bio, and you both have achieved a lot. But the main reason, Eric, you reached out about this conversation, and I thought it was good, was because Jimmy likes the numbers. He likes the statistics. He's got that brain. You kind of are the same animal. You're both built that way. But tell everybody why you thought this would be a good conversation.
So when we first started hearing about the coronavirus getting very serious in late February, early March, and one of the ways I was dealing with the stress was to dig and dig and dig and see what I could learn on the internet and just try to learn as much as I could about it. I was worried about what the infection rate was. I was worried about what the death rate was. I was worried about all that stuff because even though I'm not a decision maker in our country, that was kind of why my way of controlling stuff, of having some control, was I'm going to learn as much as possible. And along the way, as I'm digging into this stuff, there was some moments where I started having questions about, why am I asking questions that I'm not seeing anybody in the news or in mainstream kind of magazines or websites asking these questions and getting answers for them? And then a couple things along the way that gave me pause to start asking, what do we really know and what are we making our decisions on? And a specific one was when Dr. Fauci said in early March that the coronavirus was 10 times deadlier than the flu. Well, on the date that he said that before Congress, we had done less than 13,000 tests. And that just struck me as, what's going on here? We don't know how many people have actually been infected. So how can we know what percentage of people are going to die. And Jimmy and I can talk some more about the numbers. Jimmy's going to be able to crunch that stuff. But the point is, it made me a little more interested in wondering where stuff is coming from. Part of my view of this is, if you remember back in March and February and probably into April, if you talked about this stuff on social media, if you asked questions about this stuff, there was very often a response, well, you're not a doctor, you're not an epidemiologist, what are you doing asking questions? And my response to that is, the President of the United States is not a doctor, not an epidemiologist. The governor of Tennessee, Georgia, Florida, California, New York, those are not epidemiologists or doctors. They have to take the advice of doctors, but it's their job to filter through that information, understand it as best they can, and then make policy decisions. And I kind of see, well, at least on the sidelines, as a lawyer, as somebody's interested in numbers, do I think they're making good decisions or bad decisions? And why do I think they're not making good decisions? And well, in the middle of me struggling with trying to find some place where there was some sort of objective analysis, here comes my friend Jimmy LaMance, superhero with a cape flying out of his back, who's crunching numbers on stuff he's posted on Facebook. And just for a little bit of background, Jimmy and I went to Red Bank. We graduated in '85. Jimmy and I met in 10th grade when Signal Mountain Junior High and Red Bank Junior High merged together. His wife, Sarah, is somebody that I've known, I guess, since 6th or 7th grade when she first moved to Signal Mountain. And so Jimmy and I are friends of friends, and other friends of yours, Clint, Matt, Catherine Killebrew, and kind of reconnected that way. And we're hoping to see each other for dinner right when we were told we're not allowed to see friends anymore. But at the same time, the stuff that Jimmy was doing research on and talking about was exactly what I was wondering, why there isn't somebody, and why not somebody in the local TV stations not doing that? Why is somebody in the national media not doing that? And there has been a little bit more of that over time, but Jimmy was way out ahead of a lot of people, crunching numbers and asking some of the right questions, the questions that people should be asking.
Well, so before I ask you this question, Jimmy, let me say what Eric's already said. No one on this is a doctor as far as in the medical field. None of us are experts in viruses, our viruses. We're not here to tell you how to prevent anything. We're here to discuss the headlines and the stats. And Eric, you said something when this first came out, and I think this is just the nature of social media. If you have a contrary opinion to pick a narrative, whoever's saying it, a lot of times the responses are all on emotion, which I get. Nobody wants to get sick. Nobody wants to get somebody sick. I've got parents and kids. Nobody wants that. But I think that's why we have to find some place we can trust. And this has been the last 3 months. The headlines from one day will vary to the next on what is and what is not. So with that being said, Jimmy, why in the world did you start posting stuff and mess up Eric Buchanan's beautiful utopian world?
I think I started posting for the same reason Eric was digging in. I couldn't make sense out of what I was hearing. So I was watching what was going on around the world, and you could see this disease starting to hit and it progressing and countries responding in different ways. And what I was hearing from the media, social media, TV, the president, didn't line up with what was going on, what I was seeing in data from other countries. So at that point I said, oh my goodness, I better dig in and figure out what I've got to do. And literally, I think in my first Facebook post, I said, look, this is just where my thinking is. This is what I'm going to do based on my look at the data. So, here it is for what it's worth. And the other thing that I did that I was really curious about, like the United States it's not some homogenous, thing, right? People make fun of whoever it was in Alabama who said, hey, Alabama's not New York City, which, well, it's true. I understand, how that you could argue either side of that. But Hamilton County, like the disease is not going to progress in Hamilton County the way it progresses in New York City. It's just not.
Right.
So I dug in with a real focus on what's happening in Hamilton County. How much capacity do we have? What do we need to do? What does it look like here locally? So that's my bent on it.
When you first started looking into the numbers, there's a little bit of you're a little skeptical. You're seeing, I see all the headlines we saw on Facebook. There's what do you call press conferences from New York every day. There's press conferences from the big cities every day. Donald Trump and Dr. Fauci were on every day. Now they're not. Now they're just not doing that. So does that mean, Jimmy, in your opinion, the coronavirus is gone and you just don't have to worry about it anymore? We don't have, it's not the news. It must be not, it's not real, right?
Yeah, I think that's good. Yeah, I think we're done here. So
anyway, back to, let's talk about Eric.
Let's talk about when the NFL is going to start back up and if we're going to have a baseball season.
No, and well, maybe. But so let's start back where you started the first post, and you started posting the on a daily basis, so I'm not mistaken, or pretty close to it.
It was actually, it seems like it was daily because it took data analysis every day, but it was once or twice a week. Because things were changing pretty quick at the beginning. They're not changing as fast now. And it was really hard to do the analysis at the beginning because all the numbers were really small. So anytime you're trying to do statistics on small numbers and make predictions, it's particularly tricky. So it took more time in the beginning than it does now. Also, finding that like reliable data sources was not as easy.
Well, that's what I was going to ask. Where were you looking? Where were you getting your numbers from?
So right now, I think the best numbers that I've got available to me that I found anyway are from Hamilton County Department of Health. They have a web page. They update it every day. Some of the numbers only get updated Monday through Friday, but it's there every day. The CDC posts a lot of good numbers. And then there's a couple of websites that track all of the data from all over the world. And so those are, I can send you the links to those if anybody's interested. And you can go and dig out all the numbers out of all of that.
One of the things that I think it made difficult, and either one of you can comment, when this thing first started, I think it was hijacked pretty fast by political agendas, and I think on both sides. This isn't going to become a political commentary. I hope not, but it can. It doesn't bother me, but it was hijacked on both sides to almost not weaponize it, but just use it as a club to beat things into our brains. And I don't think that helped the statistics and the data coming out. Do you, Jimmy?
No, and that was one of my big frustrations. I wanted to know like what the facts on the ground were so I could decide what to do for me and my family. And that information wasn't available. There was a whole bunch of spin, and I saw it from both sides, and the spin on both sides was egregious. And the other thing I learned a couple of weeks ago, and this is a new thing about me that I've just learned about myself, I'll share here. Apparently, I'm a math bully. So Catherine called me a math bully.
Hold on a second. What'd you say, Eric?
I was just curious. That story I want to hear real quick before we get into the numbers. How are you a math bully?
We were with Matt and Kat, and I do not remember the exact context, although I'm sure she will remind me of it next time I talk to her. And I corrected someone on their math, and they called me a math bully. So
please tell it was Killebrew. Was it Matt the Red?
Yeah, it's Matt the Red Killebrew.
He's sensitive. He's a sensitive dude. Eric, you said you wanted to get into the numbers. Or Jimmy, were you not finished? I'm sorry.
Yeah, so one of the things with the numbers is, like in the headlines, what they'll tell you is, the number of deaths in the U.S. has doubled. And you got, okay, well, it went from 5 to 10. Like, so there's all this spin that goes with it that doesn't actually give you any real information. So that's why I dug in.
So let me give you, Clint, if you don't mind, let's talk about some very specific numbers that made me really scratch my head. So go back, let's get in a time machine, go back March 11th. Everybody saw this on national TV. Dr. Fauci testified before Congress that COVID-19 was 10 times deadlier than the flu. On March 11th of 2020, we'd only conducted 12,580 tests. And I'm getting my figures, and actually two different places. The COVIDtracking.com website actually shows a newer number, 12,750. So we're still talking less than 13,000 tests had been done by that day. But here, more importantly, is this. When somebody gets the flu, not the flu, the coronavirus, when somebody gets the coronavirus and they have an infection, we've been told it takes a week, 4 to 14 days, I've heard 6 to 9 days, 6 to 13 days, whatever it is, to start having symptoms. And then they go to the hospital, and then their hospitals, people were on ventilators for 3 or 4 weeks at a time and actually got off. So from the time people started getting sick and actually having the symptoms, and then getting tested. And also remember early on how limited the testing was. We just didn't have enough tests. That's why, the White House was so proud later on when they put a big banner saying, hey, we've done this many tests. Well, congratulations. Now that's too late, but it's still important to know we're getting the testing done now. So the people that might have died by Wednesday, March 11, would be people that were actually, first got sick. Let's just say March 1st. It had to be earlier than that for them to first get sick. How many tests were done by March 1st of 2020 in all the United States? And that total number was a whopping number of 126. That's all we tested on March 1st. And by March 11th, we'd still tested less than 13,000 people. How many people had died? How many people were tested positive? There were some numbers coming out of China. Do you trust the Chinese? I'm an old Cold Warrior. I flew P-3s in the Navy. I don't necessarily trust the Chi-Coms. The other numbers coming from Italy and some other places, but the testing was just starting to get started. So how the heck did we know what the death rate was, that it was 10 times deadlier than the flu? And so let's define those terms. Jimmy, you can help me out with this, but I'll do it like I understand it in layman's terms. If 1,000 people have the virus and 100 of them die, that's a 10% death rate. Or to make it even more simple, if 100 people have the virus and 10 of them die, that's a 10% death rate. If 100 people have the virus and 1% of them die, that's a 1% death rate. If 1,000 people have the virus and only one person dies, that's a 0.1% death rate. And that is about what the historical number is for the flu in the United States. Now, we can say lots of, caveats about the flu. A, there's a vaccine for it, so it doesn't get to as many people. And B, that 0.1 death rate is after we have a lot of treatments for it. Doctors know how to treat the flu, and it's less contagious, so it's only going to be in a smaller population, or maybe it's less contagious. That's something else we didn't know. But at the end of the day, if we're going to make policy decisions as a country, as a world, on how to prepare for this virus and defend against this virus, a good starting point is we don't shut down the world for the flu. If something's 10 times deadlier than the flu, well, gosh, that got everybody's attention. Well, how the heck do we know it's 10 times deadlier than the flu if our total number of tests we've done is still less than 13,000? And so that's when I went and saw Jimmy's post, and he and I kind of Facebook, commented back and forth, and Jimmy had some other good numbers, and I'm going to let him take over from there, because that was when I kind of said, well, what's going on here, Jimmy? You're doing some number crunching.
Yeah, what did you find during that time?
Yeah, so Eric's absolutely right. The paucity of testing was a real problem in trying to figure out what was going on. So internally in the U.S., we were so far behind the curve on the testing that we had no chance. Right? Like our testing data is it's starting to be meaningful now, but back in March, it was absolutely not meaningful. Because of what Eric said, it was so spotty. There was no way to get a sampling of it. Depending on how you sampled, you could get any number you wanted. And also the way that this disease, and probably all diseases, because remember, we're not epidemiologists, but it's going to spread in certain communities. It doesn't spread uniformly across the U.S. So like if you'd have taken that, 1,000 tests and done them in, Tuskegee, Alabama, you would get different results than if you'd done them in,
Brooklyn,
for example, right?
Yeah.
Just going to be different. So,
well, the cluster of population affects the spread. I mean, that's just
common sense. Yeah, a lot of people living close together, you spread it a lot more, right?
Yeah.
It just is. So that was the first challenge. That was my first real frustration. Is the U.S. government just really botched that. And some Asian countries did great. Now they had the upside of having had bird flu run through about 10 years ago. So they knew what could happen if they were not on top of these things. So they had procedures and policies and things in place so they could deal with it differently than what we do. The thing that really spooked me as I was looking at the data was okay, so first let me put the caveat. You don't always have good data. And particularly early on in something like this, you absolutely don't have good data, right? So this is like it's a fog of war thing. You show up, there's smoke everywhere, it's loud, you don't know what's going on, you don't know what's out there. What are you going to do? And you got to make decisions based on the best information you have. So looking around, the kind of the metric that I latched onto was how fast is this thing doubling? Because the scary thing about the spread of this is the doubling rate. So this is one of those examples of, let's say you have you've got a pond. This is the lily pad problem, if you've heard that one. So you've got a pond and the lily pads on it double every day. And on day 50, the lily pad is completely covered. How long, what day was it half covered? Well, it was day 49. And you only have to back up a handful of days and there's no lily pads on the pond, right? You don't have a problem. So it's doubling, this fast doubling rate. And at the time when I started this, it was doubling about every 3.5 days in the US. I started tracking the death numbers instead of the confirmed cases because of what Eric said about the testing. So under the assumption that, if people die with COVID-19, we're pretty sure they had it, right? So we're going to catch those. So you look at the number of deaths and how fast those deaths are doubling, and you get an idea of how fast the thing's spreading. So just to give you an example of like what this doubling rate looks like. So as Eric mentioned, I wrote down some numbers here earlier. So on March 10th, we had 28 deaths in the US, right? Big deal. Yeah, 28 deaths. We don't get out of bed for that. 2 weeks later, we had 590. Now you start to go, that seems like a lot. 2 weeks after that, it's 11,000. 2 weeks after that, it's 42,000. So over a period of 4 weeks, you went from 28 to 42,000. That's the scary thing. And I didn't get the impression that that we were responding in a way that appreciated how fast that was going to grow on us.
Well, and real quick, you just have to also at the same time, and this is where I'll speak for people who may not have all the degrees, and we're just out here trying to work till Friday and get a paycheck. At the same time, though, when we talked earlier about the headlines, I'm reading headlines of some places are reporting deaths if they died and had coronavirus and they tested positive for it, but they didn't die. They died of a heart attack, or something. And I know we giggle at that, but that was actually on Facebook. That was running headlines. And so we get these things thrown at us. And eventually most of us just aren't like you, Jimmy and Eric. We just go, to hell with it. I got to go to work, or I got to go to my living room and work.
You don't wake up in the middle of the night thinking about numbers and statistics and policy behind those numbers and statistics like normal people, Clint.
Well, I'm a simpleton from East Ridge. So, but Jimmy, you were in the middle of something and I interrupted you with the data as far as the headlines go, because you said it was doubling. But at that exact same moment, there's a lot of people that start questioning what you said. You don't always have good data.
Right, and you don't. So you got to make decisions based on what you got, right?
Right.
I read a long time ago, Colin Powell, in one of his books, said, once you have to make a decision, you don't make a decision until you have to make it, and then you just have to make it with whatever information you have. And the thing that scared me was because of the lead time that Eric talked about. So from the time you contract the virus to you have symptoms, I rough it in as a week just to make my thinking easy. 2 weeks, if it's not going good for you, you end up in the hospital. 3 weeks, if it's not going good for you, you're in ICU. And not long after that, you're going to die. So it's from the time you get it till the time you go to the hospital, it's 2 weeks, and then it's 3 weeks to ICU or death. So if you look at that geometric progression starting on March 10th, where we only have 28 cases, but you project forward for 3 or 4 weeks, well, right then, we're in trouble. And that message was so cluttered and polluted, it was just impossible to understand. There was one political side, and I won't name which one's which, but you guys can try to guess. One side said, it's no big deal, don't worry about it. And the other side said, oh my God, the sky's falling. We have to, we all have to run and duck under our desks. And unfortunately, that's the problem, is those are the two answers that we came up with. And
neither are helpful. Neither are helpful, though.
No, both are wrong.
Yeah. Here's what I think, and I think no matter if you're in a place that where if you're running a company or a country, it's you said make a decision, right? When you get to the point, you make a decision. Well, and Eric said it a minute ago, if you're getting fed statistics and data, you can only make a decision based off what you're getting. And if you're having this much trouble finding good statistics, I've got to be honest, I think if you go back now looking at it, things would have been said and done differently on both sides, because the statistics now are just as cluttered as they were then. I don't know if it's any better.
It's actually a lot better now.
Thank you.
The data's a lot better now. It's a lot cleaner. It's not complete. Like we still don't, like, we can't answer the question. And that's one of the problems with science that we got to be clear on. Science doesn't actually answer questions. It's only the method that we use to derive what we think might be going on. But the data's way better.
Sorry, Jimmy. I'm going to try to hold off on letting everybody know what my political bias is until the end when we have some policy discussions. But in the short run, let me just kind of say this, that what we knew at the time in February and March was, like Jimmy said, potentially really scary numbers. If you paid attention to the deaths going up, if you paid attention to the hospitalizations going up, if you paid attention to how quickly it was doubling, and if you paid attention to the modeling that was being put out, and at the time, it was awfully hard for anybody to say that model's not right because, darn it, we just didn't know enough yet. We were making decisions. So for the public policy makers, based on what they knew in, say, early March, the decisions to start social distancing and then start recommending lockdowns and then starting actually enforcing lockdowns over time, I think, from a public policy standpoint, based on what we knew, that was probably the best decision that could have been made. The questions that I think are important for us to be asking ourselves is, was it still the right decision? What are the right decisions to make going forward? Do we need to lock down again if it gets really bad? Do we stay sort of locked down in the meantime? And so in order to have that discussion, there's a couple other statistics that we can talk about. And one statistic that I think is one that's extremely controversial, and again, without giving away my politics, I'll tell you that I got into some fairly good Facebook fights, because that's, your entertainment when you're locked down in your house, about the idea that when we are locked down, we're saving lives, but we're not saving every life. Somebody's still going to still get the illness. Somebody's still going to get infected. People are still getting infected. It was still spreading some. How much did we reduce the rate of infection, and how many lives did we save by being locked down? That's the one side of the equation. Not how many died total, but how many lives did we save? And I'm going to propose that the other side of that equation is, that the starting point is, how many lives did the lockdown cost? There's been some studies, and I can send you the links to them, Clint, if you want to put it out later on, suggesting, for example, that because we stopped doing non-essential medical procedures, we stopped doing some cancer screenings, we stopped doing some biopsies, we stopped doing some other medical procedures. I read one report that an estimate from the American Oncology Association is 30,000 more people are going to die next year than otherwise would have died from cancer that was not timely treated. So when you start adding up those kind of other numbers, there's an important question we should be asking ourselves: is the lockdown actually saving a net significant number of lives? And one of the things that kind of bothered me early on, and when Jimmy and I first started talking about this stuff, is where is the modeling of what it's going to cost our country because of a full lockdown, one that includes, say, for example, non-elective surgeries going away, hospitals being shut down, just in lives alone. So if you compare lives to lives, that's an important kind of consideration, I think, that a policymaker should consider. And then on top of the lives to lives, there's obviously the other economic impact. In total, somewhere north of 40 million people have filed for unemployment since the beginning of March. And last I saw, it's around 25 million are still cumulatively out of work. What has that done to our economy? What has that done to the cost in lives? And then there's this other concept, deaths of despair. People who Otherwise, if they'd been working, if they'd been out with their friends, if they'd been out with their family, they might not have committed suicide. They might not have overdosed. Those other adverse consequences. And whatever side you come down in this debate, I think the fair question we should have been asking ourselves as a society is not just how many lives are we saving by the lockdowns, but how many lives are we costing by lockdowns? And one last point, and then I'll let Jimmy kind of respond to this because he's a better numbers guy than I do, and he has a slightly different point of view. But we're I think, working on being very good at having these conversations without making each other mad. It's just we have different points of view, and I think we really respect each other's numbers. Is kind of the last point about this. If you remember early on, there was those charts that showed a big, and I do this on the screen, a big giant, let's go this way, a big giant curve, and that's how bad it's going to be. And then there was this smaller curve that was spread out over time. Well, if you look at the volume of deaths in that big giant curve, it was really scary. If you looked at the volume deaths in the other one, it was not just the bottom of the big curve, but it was the small curve spread out over a lot longer period of time. So everybody agreed, even if we successfully do severe social distancing, what turned into being called lockdowns, there were still going to be a lot of people who were going to die anyway. So what was the difference in the numbers that we saved by locking down and not locking down? And then what was the cost in lives and in economics that maybe contributed to additional lives being lost? And I think this is a conversation that reasonable people and reasonable leaders coulda, shoulda, woulda been having, but for, I think, gosh almighty, if you don't understand the Facebook and the TV and everything else where people couldn't agree on, whether it was raining or not today, that people are not having these reasonable conversations, except for my friend Jimmy and I could exchange this information on Facebook and kind of have two adults talking, even if we don't agree on everything. And my gosh, how rare is that today?
Well, Jimmy, the floor is yours, but I'll say this: the right answer whenever we're posed with questions like this. The right answer is the one that I agree with. Okay. I'm going to go to justifymyopinionstats.com and find my echo chamber, and I get to throw it out there. Look, I'm right. So, that's what we all gravitate to. So what do you say to Eric on that right there? Because he said a bunch of stuff there.
Well, I'm going to say something incredibly controversial. I think we should be having this conversation. I think the idea that we only have two choices, you can either be all the way to this side or all the way to the other side, and there's absolutely no space in the middle, is the end of us. That's the problem. So yeah, Eric and I can talk about this. We can talk about the numbers. And one of the first things you got to do is, well, for me anyways, you've got to agree on what the numbers are. What do they mean? What are they first? And then what do they mean? What are they telling you? And what kind of decisions can you make from that? But the answer, I don't believe the answer lies at either one of the extremes. I've never found that in anything that I've built in my life, that the answer lied at one of the extremes, right? Like, you're going to build a bridge. Do you make it super duper light and flimsy, or do you make it like a complete solid chunk of concrete? No, the answer is somewhere in the middle, and the same thing here, right? So what we did was, we showed up, we had one tool in our tool bag, we had a hammer, and we just started banging stuff, right? Complete and total lack of finesse.
Well, yeah, go ahead. I'm sorry.
Well, let me talk about the numbers a little bit. So one of the things that's fascinating as a numbers guy is all the little jurisdictions and countries in different places in the world all did something different. We're a little bit different anyway. So we have a whole bunch of individual, unique little case studies that are really fascinating to look at. So my go-to, and if you've been watching my Facebook feeds, you've seen this. My example country is South Korea. So South Korea to date has had, are you ready? 274 deaths. Okay. So South Korea has 50 million people. You scale that up to the US, it's about 1,600 people died from COVID. They didn't go into lockdown. So we know that there is a way to not go into lockdown and not kill a lot of people. Now, for comparison, the US as of today has 110,000 people. So, or 110,000 deaths from COVID-19. So somewhere in between those two spans, there's some space to do things. There's some room to work, and there's some things to do. And I think Eric's absolutely right. There was no consideration of those other costs, and there totally should have been.
So, Jimmy,
Well,
let me chime in one thing real quick. So when you talk about
Yeah.
South Korea, what's one thing I think that's important for anybody who's curious and listening to this, but wasn't really following the news closely, in the United States, and correct me if your understanding's wrong, but our Center for Disease Control did not do an A+ job. When it came to testing, they had the wrong test, or they had a test that had false positives, false negatives. They had to recall it. And I don't even, what the details are not important. The important thing is it took us the month of February to start actually having real tests. And what you can do if you have good tests ready to go early is, as soon as you have a few positive cases, you can test them, you can contact test them, and isolate that area of infection. It's exactly what Dustin Hoffman was doing in the movie Contagion. Is let's figure out where that thing started and find the people that have been infected before it gets loose. And one of the terms people throw around in this is community spread. When it spreads so much that the health department and the CDC can't go back and test and trace and figure out where it came from, it's so ubiquitous, it's so common now that we don't know where it's coming from. We're past being able to track it down. Well, our problem was our testing was so screwed up that by the time we could start testing people, we lost the ability to test meaningfully, where South Korea was extremely successful in doing that.
Yeah, they actually did a containment strategy. Like, so they knew it was coming, they saw it, they had their tests lined up, and they basically just contained it, and it doesn't spread around there. That ship sailed for us, like, probably, looking at the data, late February. That we weren't ready to go in late February. We missed the boat. The reason I think this conversation is
By the
important
way,
now,
for the audience, on February 29th, we had done a whopping total of, where was it? I just had it right here, 41 tests.
yeah, that's a little undersampled from where we should have been.
Yeah.
You mean we can't make policies and decisions based off that? Okay, whatever.
Well, you can, you can sample the, 41 tallest people and take the average, and then, make all the pants that size, but it's not going to work out good.
It's not good if you're in an NBA locker room, though. I can tell you that.
And by the way, the day before February 28th, it was 9. So that was a successful day where we did a lot of tests at the end of February. And by the end of February, by the way, we took my mom on vacation out of the country to Costa Rica. She wanted to go. She's getting elderly. She wanted to go down there one more time. And we'd heard enough about the coronavirus in February that was actually a thought in early February. Are we going to be okay to travel? Are we going to be okay to go down there? Do we need to worry about, especially since she's elderly? We didn't know how bad it was. And it was so low on the radar horizon for the world that we traveled out of the country in the middle of February. I know we were gone toward the beginning of the trip was Valentine's Day. So toward the end of February, we came home and the world was normal. And the United States was starting to have some illnesses, but we still hadn't done but a total of like single digit tests because frankly, the CDC that had one job didn't do it.
Yeah, that was a failing. And I think it's a really important conversation to have now. Because if this behaves like other coronaviruses and other flus and other things like this, it's going to be back in the fall. So it's likely going to die down some during the summer. I mean, it's not right now, by the way. Certainly not in Hamilton County. It's not gone crazy either, so I don't want to get anybody all riled up. But it's not going away right now. But it's going to come back in the fall if it's like the other viruses, and we need to be ready for that. I mean, maybe it will, maybe it won't. But a reasonable person would look ahead and say, yeah, that might be a problem. Maybe I should be prepared for it.
Well, and two, if we've not learned our lesson and have kind of fixed our systems, our decision-making processes, it'll be something else. I mean, even if it's not this one and this virus doesn't adapt or change or mutate, it'll be something next year or 5 years from now. And so I'm hoping that we are looking at what we've been through and gone, this won't be the last time we're tested.
No, it won't.
Yeah. And I think you said something at the very start of this, Jimmy, that I took for granted. I just assumed, this is the devious smile on my face, I just assumed that our government had access to real time and the best data out there. And boy, they know a lot more than I do. But I've been watching it and listening to you. And guess what? I just don't think that's the case. And I don't think, and in fairness, I don't think it's an administration. I think it is the systems that we put in place are so top heavy. There's so many tentacles. It's hard to gather stuff.
Yeah, I can tell you, like from working with the government, that the government does not listen to scientists. Like we talk all this gobbledygook. It's hard to understand. We have these models that predict what's going to happen in the future. Yeah, all these people are going to die. And they're like, I don't see it. Doesn't make sense. I can't get my head around that.
Until they do pay attention, and then sometimes take their word only.
Yeah.
But even the modeling, when this thing first started, you had some models that were coming out by experts, depending on, who was paying for the studies, that said 50 to 75,000, maybe 100 or 200,000. Then there were some that were saying millions. And so you had this disparity between the two. Again, who are we supposed to listen to?
It is a really hard problem, because on something new like that, you can get 100 scientists and you're literally going to get 100 different answers.
You people are smart. Figure that crap out, man.
So let's talk about this a little bit. So what you were assuming, like, I think most lay people who were trying to do their jobs, trying to make a living, trying to get through life, didn't have the middle of the night nerdness that I had, that probably Jimmy had, that we had to go take time away from our jobs and crunch numbers. But some of the other stuff I learned by reading about this is it wasn't just that the CDC didn't get a lot of testing done. There was a major failure with their tests, the CDC's own tests, that basically they were unreliable until the end of February at least. The other problem is red tape bureaucracy. For whatever reason, and this is not an area that I'm expert in, but I can just tell you the result of this. The CDC had a policy that, number one, they weren't going to use a version of the test that had been created by the World Health Organization because, well, that's their policy. They had a rule against it. Another rule that they had was that the state health care systems, the state departments of health most specifically, but also including, say, private and public hospitals, were not allowed to develop their own tests until the CDC gave them permission to do that. And the CDC was so concerned, for whatever bureaucratic reason, in maintaining control of the testing early on, that, for example, when the very first cases were starting to test positive in that nursing home near Seattle, that the governor of Washington basically said, we need to test. The CDC said, you can't do your own test. You have to use our test. And what I understand, there was actually a bureaucratic kerfuffle where the Washington Department of Health went ahead and broke federal law and started doing their own testing, and got forgiven after the fact when the coronavirus task force took over, and we started talking about cutting red tape and allowing states to do their own testing and allowing other places to do their own testing, which raises a really important policy question that I think the public should be thinking about now that we're starting to get through this. Why do you have that red tape in the first place? Why was it a rule that they couldn't do their own testing unless you just want to maintain the quality control? But if you're at the crucial moment, like South Korea had control over, where you can contact trace, why would you have a red tape rule that caused potentially the huge number of deaths that actually happened in the United States?
Yeah, Jimmy.
Yeah, I got no idea.
Anything in there, Jimmy? Is that your understanding as well?
That is exactly my understanding. Apparently, Germany had tests that were good. South Korea had tests that were good. We were having problems with our testing. I had no idea why we didn't call up our friends in Germany and Japan and South Korea and say, hey, can I buy a couple of those until I get square over here? It doesn't seem that hard.
Another conversation that I think is hard for people to have, because we don't do it every day. You're an attorney, you're a scientist, and I've got buddies who are insurance folks. And so they're used to these conversations where you make policies based off risk, right? So some of the conversations I saw on social media, again, there was emotions involved, understandable, but it's not worth one life to make this kind of policy decision, or to shut things down or open them up. And I agree. Let me tell you when it's not worth one life. When it's my life or my family's life or my friends, then that's my statement. But in reality, we make decisions, insurance companies, you guys, we make decisions all the time based off the risk and of the consequences of those decisions. It's hard, though, when we talk numbers, when you start putting names to it, that's when it starts meaning something. And there's some hard decisions that people are going to have to make if this comes back around for a second wave.
Can we take one pause for a second? We've got a comment
No.
over here, and somebody said, it sounds like we had a trolley problem when we were talking early on about the lack of testing. Jimmy, have you heard that phrase before?
I think that's a reference to a philosophical question. So if you're the trolley driver and there's a fork on the track, I'm trying to remember exactly how this is structured. Do you remember it, Clint?
Yeah, if I'm not mistaken, it's a thought experiment in ethics modeling and ethical dilemma, generally considered representative of a classic clash between two schools of moral thought. Isn't that where you've got your family member on one track and 9 people on the other, and you have to make the decision of which track you go?
Yeah, and so that's the, that's part of what we were dealing with. I think that's that reference to the trolley problem. So do you kill one person in your family or 100 strangers? What do you do?
Right, and it goes back to the dilemma that I was talking about, that originally we knew we were going to save some lives if we told everybody to stay at home. What we didn't talk about yet was how many lives we were going to save or cost by having people not being able to go get emergency treatment and being able to go get, inpatient. Well, just the cancer testing is a good example, but it's all the other testing people would get, all the other stuff that's going on when they're going to the hospital. And I heard people, and unfortunately it was like kind of people asking these questions on social media, but I never heard anybody at the government level asking the question, hey, where are the models to predict the cost of the lockdown? And so I think now it's become a fair question, and I think we'd be better prepared for that going forward. Okay. Thank you for figuring out what the trolley problem was. That had my attention. So let me talk a little bit more about a couple other statistics I thought were really fascinating as we started going through this process of trying to figure out the cost of the lockdown and whether the lockdown was a good idea. And one story really struck me as important, and that was that in late April, the state of New York did a study of everybody who was admitted to the hospital during a certain week in late April. And in that study, and by the way, there's a link to this I can send to you, Clint. It may be already in the email I sent you, that was on CNBC. So whatever your politics are, if CNBC reports something about Governor Cuomo, I'm going to guess it's going to be fair. And it was actually taken directly from a PowerPoint that he did. And what they found out was we'd been in the lockdown by this point in late April for 4 or 5 weeks, effectively, in New York. New York, I think, was about the middle of March. And so after being in lockdown for 4 or 5 weeks, it was fair to start asking the questions: do you work from home? Do you have a job? Are you staying in the house? Are you in a nursing home? They collected that data over that week. And what they found out was that if you added together the different categories of people that basically either worked from home, were retired and living at home, or for whatever reason were not getting out of the house other than to go shopping and do essential activities, that was 66% of the infections coming into the hospital in New York, where this area was hardest hit. Then another 24% of the infections were the ones coming from nursing homes, assisted living, and other congregate living, like group homes for people who, with special needs, that kind of stuff. So that's 24% of the cases. So the lockdowns are in place in New York. You go to the hospital, you ask these people, where you been? How'd you get sick? And 90% of the people were doing what we were told to do to not get sick, which was to stay in the house. Now, there's been some theories, and I'd like to hear Jimmy's thoughts on this, but one of the theories is, well, in New York, you're probably living a lot closer together. There's probably more multi-generational families. And one of the things that we've kind of learned is that the virus is more likely to spread if you're around somebody a whole lot. So if the kid who was going to college, the college closed down in March, moves back into the house where there's mom and dad and maybe grandma, and they're around them all the time, the kid happened to get it before school got out, when they were at spring break, or when they're, before New York shut down and they're out seeing their friends, or just during the kids going out doing normal stuff because they're a college age kid, whenever they finally stop doing that, somehow grandma still get. something was happening. Now, there's a little footnote to that. There's also a concern that in mid-March, New York had actually made a rule that they didn't want elderly people going to the hospital with coronavirus, and they actually had ordered that they go back to the nursing homes, which I just have not, that we can have a long talk about that. But I've talked a lot.
I don't think we have to talk about that one, Eric.
Do what?
I don't think we have to talk about that.
Yeah.
Yeah. That's in the bad decision category. Yeah. So Jimmy, what do you think about what's your feedback on what Eric said?
So I want to introduce a new concept because there's not enough gray in this thing already. So I want to introduce the concept of viral load.
Is this why you wore a gray shirt, by the way?
Propaganda.
So, I don't believe the answer is on the political right and the answer is not on the political left. I don't believe using the hammer is the answer. The other thing that we got to understand about this, or I think we need to understand, is that viral load is something we have to think about. So the coronavirus it's not like being pregnant, right? Yes, it is binary. You either have it or you don't. But just imagine, for whatever reason, you end up in the ICU unit at Erlanger with somebody with coronavirus, and you go right up in their face talking to them, and they start sneezing on you, right? Now, you're going to get a whole lot of coronavirus right in your face, and you're going to get a huge viral load. So what your immune system's going to have to do to respond to that is really radically different than if you go to the food city and, you touch a surface that, somebody had touched 5 minutes ago and you picked up a little bit of it. So it's that load and your ability to cope with that load that makes the difference. So I'll try to tie this all together in a second. So if you're around people a lot that have it, and most of the spread we think right now is via droplets. So when you talk or sneeze or cough, but just talking loudly, all the droplets that come out, that's where most of the spread comes from. So if you're around people and you're talking to them all the time and somebody has it, you're going to get more load from that than if you arbitrarily picked it up at, off some surface somewhere. The other thing that comes into this is, and I'm sure we'll talk about how many people are asymptomatic. There's a lot of people who are asymptomatic, right? So they have the virus, their immune system deals with it, they don't ever really get sick. So you can still get it from those people, and we don't know what the number is, like how contagious those people are, and there's like all kinds of radical different stuff that's come out in the last couple of days on it. But when that happens, we have this other, with the people living so close together, you get this effect that you're going to get a lot more load and you're going to have a harder time dealing with it. The other thing we got to know about the numbers here, as we go on, this is not dangerous for the three of us, right? If you're under 60, this disease poses almost no death threat. Your threat of dying from this is very, very small if you're under 60, unless you have some other compromised situation. If you are over 60, this thing is really, really nasty. And we can get into what the numbers are, but it's really brutal if you're over 60. So if this thing gets turned loose in a nursing home, it's a bad, bad thing. And we see that all over. It started in Washington State, but it's all over the world. You'll see like huge numbers from these clusters. And so the thing spreads in these clusters like that. So that's why, just lock everybody down. If you only have a hammer in your bag, that's what you do. But boy, it'd be nice to have another tool.
But I don't know if we knew when that was, locking everybody down. And maybe we did. And maybe we had the data that showed that it was super affecting the over 60 crowd to the degree it is now. And maybe we did at the time. I think that's a little bit of what the trolley thing was too. Do we make decisions to save those, or you know what I'm saying? A lot of gray.
Yeah, and I agree with Eric that, like, in the beginning, if you go look at my original Facebook post, man, I put up the red flag like, hey, we better do something. This is going to get real if we don't. Well, we did something. We did the lockdown, and then like about 3 weeks later, I was watching the data and everything went flat. And my concern wasn't so much like no deaths. My concern was I don't want to overrun the healthcare system. Right. we have a limited number of ICU beds. In fact, we have 331 ICU beds in Chattanooga, right? So if we end up with 1% of the population needing ICU, we've got a real big problem. Lots of people are going to die. That's what I wanted to avoid. So in the beginning, we didn't have good data, but about 3 weeks in, we kind of knew what was working, and we could have been talking middle of April about, like, how do we open up? What do we do now? How do we change this? We've got it under control, at least here in Hamilton County. But the idea that we're still, in this state, God, how long's it been? 2 months, 3 months? I've lost track of time. And I majored in time.
It's Tuesday, April of 2016, I think, or 2019. It's a Wednesday, Thursday morning. Well, and there is such a thing. And again, this is when I get to repeat stuff that I've heard, but I have no idea what it really means. This is the great thing about doing with this job. This part, the herd immunity. I mean, I understand what it means, but you have to have a certain percentage of the population to actually get the virus before your bodies as a group starts producing enough to where, okay, we can fight that off. And I don't know if it's 40% or 60%, but you kind of, we don't get there quick as we should if we're not around other people. Is that right or wrong?
That is right. The flip side of that is if you said, okay, well, let's just magically do herd immunity in Hamilton County, and let's just give 50%, because you're right, the number is somewhere between 40 and 60. We don't know what it is, so let's just use 50. So let's give 150,000 people coronavirus. Let's say half of them are asymptomatic. So now we got 75,000 people. Well, we know of the people who are symptomatic, you end up with about 1.3% in ICU. And so do 1.3% of 75,000 and we're screwed.
Yeah.
Right. Like game over. So that's not a valid, it's not a valid path when you run the numbers out.
Right.
In the herd immunity thing, here's the other thing that I find fascinating. The other country I like to watch is Sweden, because they publicly came out and said, we're going to do the herd immunity thing. Their death rate or their death total today is, when you scale it up to population, is actually a little higher than ours. So they've had 4,600 deaths across 10 million people, which if you scale it up to the size of the U.S., it's about 138,000 deaths. But the thing that is fantastic about Sweden, and the thing that they do great, and I think we should really pay attention to, is their health department came out and said, hey, this herd immunity thing may not be working out the way we thought. We might have to rethink our strategy. And everybody went, oh, okay, we can rethink our strategy. So just imagine that happening here. Somebody in the government saying, we might have made a mistake. We'd like to change that now.
The problem with that is, though, the problem if that happens now, and it doesn't matter if it's 7 years ago or 3 years from now. So this isn't, but if that happens now, you have a whole another team that is designed to take, oh, you didn't know what you were doing to begin with. Does that mean you were wrong? In other words, they'll weaponize the fact of you're having to change and pivot.
But the reality is, in a situation like this where you don't know what's going on, you probably need to pivot at some point.
Yes.
Like no good plan survives first contact with the enemy. Right, that old-fashioned Sun Tzu. So, like, take that away, and it's boy, that's tough.
Everybody's got. Now, I'm more of a Mike Tyson guy. Everybody has a plan until they get punched in the face.
So let me introduce one more extremely difficult concept, and it's a difficult one because it goes back to that idea of even one life lost is precious. Yes, that's true. But at the end of the day, as a society, we were deciding between the people on one track or people on the other track that if we lock down and don't do hospitals being open for elective surgeries and for cancer testing and detect heart problems, and there's deaths of despair where people commit suicide and the drug overdoses because people have been locked in their houses. So just if you start with that premise that at the end of the day, some people are going to die on either side of that scale, that when we're actually measuring how important the lockdowns are or the quarantining of society is, that balance is a little closer than we first thought. I think that's probably maybe a fair way to put it. And we need to model both. Then the other question is, when you early on Facebook and other social media, you saw people talking about the Spanish flu and the second curves and the stuff that would happen with the Spanish flu, which I thought was kind of interesting because the same people would immediately respond to any serious questions about that with, it's not the flu. But okay, leave that aside. Influenza, Spanish flu is an influenza, is a flu. This is different. This is a different type of virus. One important difference that we just talked about that Jimmy pointed out is that a lot of the people who are severely affected are the people over 60. That if you're over 70, it's really bad. If you're over 80, it's oh my gosh bad. And if you're in a nursing home, then it's seriously bad. So can we as a society now take this knowledge and say, if you're going to go visit your grandmother in a nursing home or your mom in a nursing home, that you should quarantine, you should stay away from the rest of everybody, and you can go see your grandma. But if you don't have somebody in a nursing home, if you don't have somebody that's vulnerable, you should go about your business. And if you get sick, we're at the point we've figured out enough, we've got enough hospital space, it's going to spread around. And now here's the really difficult part of this conversation. If we're going to measure the lives on trolley car track 1, I'm glad we came up with this analogy and found it. And
let's just thank Kelly, but continue. Sir.
Yeah, thank you, Kelly, for bringing this up because it helps explain this so much. If you got the lives on trolley car track 1 are the people that are going to die if we get old people exposed, mostly old people with a very few young people, versus people across all ages that are going to die because they're not getting medical treatment, because they're going to commit suicide, etc. That there's this concept called life years lost. And as a public policy, it's a very difficult question, but as a public policy person, you don't make the rules so that no one's going to die. If the rule was no one is going to die, we would set the speed limit at 35 miles an hour or less. We would have other amazingly strict safety rules that we could do. We would get rid of cars. That would guarantee no one's going to die. So we accept as a society a certain number of people are going to die. And if it comes to cars, usually it's younger people. That's horrible. But it's part of society. We accept that as part of our freedom. People want to drive around the road. It's America. By God, I want to drive my car. Life years lost is the idea that if we're going to lose 100,000 people, God forbid, that's what we lost so far is 120. If we're going to lose another 100,000, but those people are all people that were within a couple years of dying, then we've only lost a couple 100,000 life years. I say only. I mean, it's just one of these academic conversations. You just got to get through the fact that we're talking about real people and real lives. I promise I'm not being non-empathetic and non-sympathetic. I'm saying from a public policy person point of view, we have to make these decisions. Somebody has to make these decisions. And the other side of the spectrum is, in the Spanish flu, Jimmy and I are both doing some research on this, reading a great book called The Great Influenza. And one of the big things about the Spanish flu is it knocked people down very quickly, and mostly people that were teenagers to their early 30s. They were the worst affected. Well, in our lockdown mode, the people who were most affected by the lockdown that it cost lives were people that might have lived much longer if they'd gotten cancer treatment, if they gotten heart treatment. Or the really worst part is the younger people that committed suicide or had drug overdoses or other deaths of despair. And it cost a lot in life years lost. I'm not saying that this is the only guide people should use. I'm not saying it's the only answer for public policy purposes, but I think it's something that's a concept that people should be aware of. And I think it rolls in, and I'm going to let Jimmy talk some more because I've talked so much, that into the idea of it's not one end of the spectrum or the other end of the spectrum. It is where in the middle can we find the right balance between not locking down too much so that we ruin the economy and cause too many deaths of despair, let people get the medical treatment they need, but not being so wide open that we end up with the maximum deaths all happening at once, which would, and this is a concept we actually just want to remind everybody, the whole point of the curve was if you have too many people sick at once, let people out at once, go for that herd immunity, and 1.3% of 75,000 people are in the ICU all at one time, more people are going to die than would over time because the ICU is not going to be ready for that volume. And that's how you have people in the hallway who are not getting the appropriate treatment. So these are all things to consider, and it's not simple, and it's kind of, you got to think about it a little bit. Lawyers learn to do this. Think about it a little bit objectively and step back to balance the interests of which lives on which trolley car track. And I'm glad I'm not governor or president.
So Jimmy, do you have a response to that? Because earlier when we talked, I brought that up a little bit in a different way, but it's that conversation of This is very easy for me to discuss when we're talking about numbers until it's my grandmother or until it's my mom. And so that's why it's a hard decision, because when you start coming down to that level, you can't make public policy based off your grandmother.
You're absolutely right. And, Eric's right that, there's these unaccounted for or untalked about consequences from the lockdown. And we need to do better, right? The lockdown's not the answer. Maybe the lockdown is the answer at some point, but it's not the answer to be completely locked down for now until whatever. The other thing, the other thing that's going to change is next year, if things go the way they normally go with these sorts of things, next year, this will come back in the fall when flu season starts. It'll be really bad. Sometime, hopefully in maybe 9 months from now, we'll have a vaccine that starts getting out. And once the vaccine gets out, then we're going to have a lot better control of this. And also we'll have that between that and some herd immunity, this is going to look really different. This is a short-term thing. It's going to end. And it's probably going to end in, 18 months. This is going to be mostly behind us. And it's going to be like it'll be a nasty strain of the flu, but it's going to be like the flu in a lot of ways. Now, by the way, just, when people say it's like the flu, I've been looking at some numbers from the CDC on COVID, influenza, and pneumonia, and they track those three together because they're all the same kind of respiratory disease. And COVID doesn't track like the flu; it tracks like pneumonia. So when you think about, I'm going to go in and I'm going to, like let's say I've got it and I'm going to contaminate somebody else, you're not giving them the flu; you're giving them pneumonia. So that's the idea to have in your head about like how bad this thing is if you're old.
So say that one more time. Explain the difference to me one more time, just so I can hear it twice and maybe understand it better.
So if you look at the deaths from the flu, the deaths from pneumonia, and the deaths from coronavirus kills like pneumonia kills. It doesn't kill like the flu kills. So when we spread it around, we're not spreading around the flu, we're spreading around pneumonia. So if you have had pneumonia or you've watched somebody go through it, it's different than the flu. It's a lot tougher. Yeah. So when you think about it, like this comparison, like it's just the flu, well, that was ill-advised language to start with.
Very well done, sir. You struggled with that, and I'm proud of you, sir.
So let me bring up a couple more concepts. One more I want to talk about is we haven't actually put a number on that. And one of the interesting questions about determining from a policy point of view, from a public policy, public health point of view, is it worth these big lockdowns, or what degree of lockdowns are worthwhile? Comparing it to just say the flu, where we don't lock down, to maybe this pneumonia type virus, we need to lock down if it's going to kill a certain number of people or impact the healthcare system that much. The important question we need to know, if we're policymakers, is, well, how many people are going to get sick? How many people are going to need the hospital? That's one of the really key ones. And how many people are going to die? So here's some stuff we've learned lately. I think the percentage of people who actually are going to get symptomatic is probably somewhere around 60%, according to the CDC. Just recently, we've learned that. And Jimmy came up with a number earlier that people get infected, so that about 1.3%. Was that for the ICU, I think, Jimmy?
That's the ICU rate from confirmed cases.
Right. And so one of the other factors is we're still scrambling to figure out how many people have been infected in the past, so we can add up what is the denominator, what's the total number of people who've ever gotten sick, so we can figure out this percentage of people that actually have been infected. And then we got to clarify, there's two different tests. There's the IgG test and there's the IgM test. And I'm not a scientist, but I read a lot. And IgM, the way doctors talk about this for lay people, is it's talking about the antibodies that are produced in your body. If it's IgM, they say, the way I remember that is it's in the moment. That's the test that says I'm sick right now. The IgG test, they say the very simple layman's explanation is it's gone. It's the test that says I have the antibodies after I've recovered from the illness. We've had all kinds of a mess. We've had Virginia and California and Georgia and I think some other states at times reporting the total number of tests that they did combining IgG and IgM. There's even been some reports that the CDC has done the same thing. So if we're trying to count how many people we knew about, how many people we didn't know about, and how many people have been infected, and then some of the early tests that were done for the antibodies for the IgG, were they gone or not? They went out and tested in California in a couple of places, and I think eventually in New York and a couple other places. And they did these tests where they said, we're going to try to make a randomized sample, find out how many people actually have the antibodies, compare that to how many people we already tested that we knew had the current infection, and estimate how widespread the infection has become in the population. And one of the interesting things that came out early on is, say, in Santa Clara, California, that the rate of infection was 55 to 80 times higher than the known infection rate based on the current testing at the time. Now, there's been some questions about that report, about the accuracy of the test, and that's been one of the ongoing problems is if that's true, then the denominator is significantly higher, and we can take a better stab at the death rate and the hospitalization rate. I think more of the antibody testing that's happened has actually kind of narrowed that number down. And this is just my reading of it, and I'll throw this back to Jimmy, is that the death rate, the best we can tell, according to what the CDC has said recently, based on the best estimates, is about 0.26%, which would be 2.5 times the flu. But A, Jimmy's right, it's pneumonia and not flu symptoms. And B, that percentage is not the only number to look at, because if it spreads more and more people have it, then you end up with a bigger percentage of the population who actually get sick and die, in theory. But we just don't know those rates to really make the ultimate public policy decisions, because we really are still struggling to figure out that denominator. Jimmy, what did I get wrong?
Well, you're right that figuring out that number is hard. So I'll introduce two new concepts because we don't have enough going around here. So,
Clint, are you doing okay?
I'm good. And
how are we doing on time, by the way? I don't want to make Jimmy stay too late. I'm doing great. I've got like one more topic I wanted to kind of cover, but are you okay?
I mean, Jimmy, are you okay?
I'm okay.
Yeah, we're good.
So two of the terms that the epidemiologists talk about are infection fatality rate and case fatality rate. So a case is a known diagnosed, you took the test, you tested positive, you are a positive test, right? So we have pretty good numbers for case fatality rate. We don't have good numbers for infection fatality rate because of what Eric was talking about. We don't know how many people were infected. We don't know how many were infected and we didn't know and they recovered.
A quick question, before we move on, so I know terms. When you say case, is that asymptomatic or symptomatic?
Just test positive.
Okay, I just making sure I understand. Okay.
So it means you took the test, you tested positive at the time.
But you may feel good, you just test positive.
Yeah, so you said, man, I don't know, I'm a little worried because I'm going to go visit my grandma in the nursing home. Gotcha. So you went to one of the free testing sites, you felt fine, and they're like, yeah, you got it, dude. And you're like, okay, so that's a case.
Gotcha.
So it includes both. The infection fatality rate is across the whole population, and we don't know what that number is, right? So we don't know how many people have been infected, and the estimates are, well, they're more like guesstimates than estimates, really. They're wild and all over the place. What I do, just so you know where my thinking comes from, we can kind of back in what we think the impact might be by using the death numbers. I think the death number is pretty reliable. We know how many people are dying related to COVID-19. And I know that people have this hang up like, well, they really died of a heart attack or they died of something else. Yeah, you're right. You don't die of COVID-19. You die because you stopped breathing because your lungs filled up, right? I mean, that's a hard way to say it, but
right.
And probably had other factors. Most of the people that die from this have other morbidities that are associated with it. So, that number is somewhere between, I think Eric's number of 0.2 is, looking around the world, it feels like it's on the low end. but I couldn't tell you he's wrong. I've seen numbers go up to just over 1%. So, it's somewhere between 0.2 and 1% of infection fatality rate. It's probably, it's in the middle of that somewhere, hopefully on the low end, for goodness sakes. So I think we need to be able to make decisions based on the data that we have, and we can back into some of those numbers without having to infect the entire population and see what happens.
But okay, this is a great layman's. And Jimmy, were you done with that point, or did I interrupt you?
Go ahead.
Sir? Okay. But the more people that have it, let's say we find out way more people have been exposed and they have this or they have had it. That's not a bad thing if more people have had it, and that actually lowers the death rate, right?
That's right.
Yeah.
Yeah.
So testing is good for that reason.
Yeah. The idea that testing is bad just baffled me. More data is more better. I say that all the time. It's just good grammar too.
Well, now you sound like you're in my circle of friends. So now you're officially Jimmy. I'm not calling you Doctor period anymore.
So Clint, can I introduce the one other topic I want? So I kind of said that I previewed this early on, that I'm kind of interested in the public policy standpoint side of this. And from a public policy standpoint, we still don't have all the information. Jimmy and I have both done some research. We've got some rough numbers. We don't know what the total infection numbers are, that denominator that everybody talks about. There's a lot more testing to be done. And there's another layer that as we go through time, doctors get better at figuring out therapies, which hopefully will reduce the death rate of anybody who actually gets infected or is a known case, the two things Jimmy just talked about. But the really big question to ask as a society is, we know it's going to cost a lot of other lives now that we've thought about this in terms of the poor medical care and in terms of the deaths of despair, plus the economic impact has been tremendous. And not just the total of 40 million jobs lost in the United States, but the fact that 20-something million people are still out of work. But remember those horrible stories we saw about the supply chain being broken, where pigs were being slaughtered and not hauled off, that whole food factories have been shut down, that milk was being dumped. I haven't seen that much lately, but for a while that was getting really scary. Are we teetering as a society because of what we did to ourselves in the lockdown? There was some really scary stuff going on. And now I'm going to kind of expose my point of view a little bit. In 1969, the Hong Kong flu, which actually went from 1968 to 1970, killed 100,000 Americans. If you adjust that for the difference in population, the increase in how much bigger the number of people are in the United States is today, that would be the equivalent of 175,000 people dying from the Hong Kong flu. In 1968 to 1970, when 100,000 people died, 175,000 today. Clint, do you remember who won the World Series in 1969?
No.
You remember the movie Oh God with John Denver and George Burns?
Yes.
George Burns tells John Denver, "I'm not here to perform a miracle. The last miracle I did was the 1969 Miracle Mets."
Oh, okay.
That great baseball season happened while the Hong Kong flu was going around. What else happened in 1969? The Atlanta Pop Festival had 100,000 people attend it. There were 350,000 fun-loving hippies who got together at Woodstock and sat out in the rain and the mud while the Hong Kong flu was going on. Vietnam protests were going on. It's going to be an interesting experiment to see what the protests are today. We haven't covered this yet. Just for anybody who watches this video later on, we're 10 or 11 days after Mr. Floyd was tragically killed by that police officer. And so there's still some social unrest going on. Hopefully we get past this soon. Hope to God we all heal, love to their families, and let's come together and respect everybody's race and stop racism. But
can't wait till that next podcast.
Yeah, that's good. That's a different topic. My point is, if you look at what was going on in 1969, the Vietnam protests were still going on. Ted Kennedy drove off the Chappaquiddick Bridge. Monty Python aired its first show. The PBS first aired on TV. The Beatles released Abbey Road and performed on the roof of their building. Nobody can remembers that it was also the year of the Hong Kong flu until this one hits and people start asking, well, if we did all that in 1969, why the heck are we shutting everybody down? And is it that much worse? And then the really tough question I'm going to kind of throw to Jimmy is, how much worse does it have to be than the Hong Kong flu to justify not shutting down, shutting down versus not shutting down? And I know you're going to say it's on a sliding scale, so there's your softball.
Wow. I think you just answered it. Jimmy, you don't even have to answer, sir. No.
I think I can put some bounds on it, though. So absolutely right. It's on a scale. We don't know. But we can bound it a little bit. So some of the new, there's two things that have come out in the last couple of days that I found pretty interesting. The first is some analysis from The Economist that looks at a statistic called excess deaths. So how many more deaths are we having right now than we would normally have right now, right? So as the year progresses, deaths increase in the winter, they decrease in the summer, so it makes this nice little curve. And it's reasonably consistent from year to year. You have a bad flu year, you'll see a little spike in it. But what The Economist came up with is in excess deaths is we are having more excess deaths than we are even having COVID deaths. So they think the COVID deaths are actually underestimated in the excess death numbers.
Now, Jimmy, can I just really quickly challenge you there? The other side of that argument is that the excess deaths could be also explained by the deaths of despair, the suicides, the overdoses, the people who didn't go to the hospital when they had heart problems because they didn't want to go get exposed to the coronavirus. I don't have an answer to that. I'm just going to throw that out as a counterpoint to that. The coronavirus is really killing more people than we thought. Well, how do we know that?
Well, we know, like if you go look at the Economist thing, they'll show they did it by country. The U.S. wasn't in the study, by the way, which was interesting. So they looked at how many COVID-19 deaths they had versus how many expected deaths. And they were getting numbers like 96% of the overage that they had. So let's say normally you had 100,000 deaths, but now you had 120,000. What they were seeing was of that 120,000, COVID-19 accounted for, of that extra 20,000 in that number, the COVID-19 accounted for 19,500 of it. Like the COVID-19 was a huge component of that signal. Of that data that we were looking at. So the excess deaths are driven by confirmed COVID-19 cases. Now, some of the extras in there, does that mean we're underestimating COVID-19, or is it some of the things you're talking about, don't know, may not ever know the answer to that.
Well, and the other thing that, we don't know is, there were people that would be driving that weren't driving. There were people that, there's accidents that were, they didn't have because they weren't on the roadways. And I'm sure somewhere in the data is the truth.
It's somewhere in there, and we'll know, in 30 years, we'll have a great data set, and some bright young kid will get a PhD going through this and analyzing it, and we'll have the answer then. But it's a little late to make policy decisions based on it.
Yeah, I guess, and the other thing is, and Eric, are there any more stats you want to bring up? Because I got a couple of points I was going to bring up, and I want to make sure, though, you get all your stuff in there.
Those are the main points. There's some other things depending on what you bring up, but
Well, I was just going to say, one of the things that has frustrated me the most, and you guys are handling the data part of it. And let's see here real quick before we do this. Let's just bring this up if we can. Can y'all read that? Yep. 17,000 from 1940.
Yeah, so let's
175,000. I'm sorry, I couldn't read it.
To clarify, the 175,000 deaths, the 100,000 deaths was from 1968 to 1970, not 1960. So it was over basically the year and a half that the Hong Kong flu ran its course, which is similar to what Jimmy mentioned earlier, that the coronavirus is sort of expected to do. Is it's hitting now, it goes down a little, it has another spike. But it's a fair question. If it's 100,000 then, and today that would be 175,000, and we're already at 120,000, in the next spike, are we going to have another 60 or 80, or are we going to have another couple hundred? But then it still raises the question, I think a fair question, even if it's 200 or 300, is it worth the cost to America, to the society, to the world, to have not had a baseball season, to not had a football season, to not have to have all our supply chains broken down, to have the people not get their medical treatment they were supposed to get, the people who didn't get treated for cancer, all of the misery of 40 million people at one time or another filing for unemployment for the very first time. All those things add up. I don't have the answers to that. I have some thoughts on that. If you ever elect me as the president or the governor, I think I'd be able to make a decision. But for today, I'm just throwing it out there as that's at least the questions. I think it's fair to say, right, Jimmy? That's the questions that people should have at least been having a conversation about.
Yeah, and it's really, really hard. Like, we don't know what that number is. I saw a study today, and I've not had a chance to read the whole thing because it's like a big, thick, science paper, and it was published in Nature, and it's got like caveats all over the thing, so it'll take a while to dig through it. But it was from some epidemiological modeling that showed how the model worked before lockdown and after lockdown. So the model predictions were really accurate up until May the 4th. And then I'm not sure what, or maybe it was, I think it was May the 4th that uses their cutoff date. And they looked at what happened in the lockdown versus the real numbers that we experience versus the projections if we had not had the lockdown. And the projections they're big numbers. It's not going to, the numbers they're projecting were not like, you lock down, you get 120,000, you don't lock down, you get 150,000. The numbers were like, if you lock down, you get 120,000, that we know. If you don't lock down, the number was like 600,000 or 800,000 plus or minus a bunch. So as a public policy person, you got to go, boy, if that 120,000 hurt, what does 600,000 look like? And somewhere in there, you're right. I mean, there's still room to do things. There's still room to move. The fact that we can't talk about anything other than lockdown or don't, that's where I think the fundamental problem is.
Well, I want to put everybody who's the social media expert on the Constitution today and viruses tomorrow. I want to put this in your head. That sounds great when we're saying, I would do this. We can say that on social media because you're not pushing the button to say, if I'm wrong, there's another 400,000 lives that are completely gone and families destroyed. So It's easy for me to say. The flip thing is I was going to bring up is the perspective. This is the only thing I can contribute, I think, to this is I wish people would, on social media especially, go to places like your page, Jimmy, go read your thoughtful post, Eric, go to some sources they trust. But I wish we would stop I'm not wearing a mask because I believe this. And if you wear a mask, you don't. I'm going to go have a beer no matter what you say. Because what I've learned is people do not know what's going on in the car next to you. That person, I've got a good friend that finished chemo in January. Well, he looks healthy. He's a good dude, but he wears a mask and he's a little scared. And the reason I bring that up is he gets in these little back and forths with people. They don't have a clue what he's been through. You don't know, like Jimmy, you were saying, you don't know that the reason you're doing a lot of social distancing so you can go see your family. And I just wish we would take a little bit of grain of salt and just say, Jimmy, you do what you need to do. I'll do what I need to do. And no judge. It's okay. It's okay.
So if you don't mind, Clint, let me just touch on one more thing, because to make those decisions as a society and to have us, what's important when people like us talk about this is we're hopefully educating other people, that it's important for us to buy in, that if the government says this is the best thing to do, are we agreeing to that? Early on in this process, I think there was no problem telling people, stay home for 2 or 3 weeks because you do not want to get your neighbors sick, especially your elderly neighbors, and everybody was totally on board. And then when down the road, as some of the numbers didn't necessarily make sense, and as governors, I think, maybe overreached in exactly how much the lockdown affected, like you can't buy garden tools, even though you're stuck at home and you can't do your gardening. I think those are kind of things that got people's attention. When you don't have consensus of everybody before that it's the best thing to do, you start to have some problems. And selling the consensus is hard to do in America because we're so polarized. But if you can back it up with the science, back it up with the stories, well, one of the things that we've had problems with that is hard to keep a consensus anymore was the whole story of the modeling. That the models were predicting 2-3 million deaths or whatever it was in the United States. The London Imperial College of Medicine models were huge numbers. And then as we learned more, we got better at that modeling, but we still had huge problems with the modeling, and we didn't really hear a discussion from our leaders saying, okay, this is why the model is working this way. Now that we've learned this, we've readjusted the model, and here's what it is. They didn't give us those explanations. They just kind of every once in a while changed the model a little bit and said, just trust us. And one of the things that I found out along the way, because I've talked to people involved in Tennessee state government who were on the Tennessee Reopening Commission. And if you guys remember, in Tennessee, there was a period in there where the Tennessee had set out safer at home, or whatever the program was, that was not an order to stay at home, but it was telling everybody to stay at home. This was in mid-March. And the order for the request for everybody to stay at home and practice safer at home, basically social distancing, was put out by the governor, and immediately there was this big push by a bunch of doctors. I don't know if you remember this, Jimmy. There was like 1,500 doctors that had done a video petition where they were all saying shut down, shut down, shut down, shut down, lockdown, lockdown, lockdown. And the governor conceded, ordered the lockdowns, doctors were fine, and we started the lockdown period that lasted for a few weeks. What I found out later on was the model that was based on didn't have the Jimmy's gray shirt mid-road numbers assumed in the model. It either assumed that no social distancing was taking place or the lockdowns were taking place. There was no credit given in the model for the fact that people were willing to engage in safe social distancing voluntarily. So the message that had been given to all these doctors from the science community was, in order to get the model to show the numbers are super low, you have to say the magic words lockdown. Otherwise, the model doesn't assume any credit for the social distancing. And that got all the doctors to say lockdown, lockdown, lockdown. The governor responds and orders a lockdown. Later, when I talked to somebody on the reopening commission and said, did you know that was true about the model? This is 3 or 4 weeks later. No, are you kidding? That was part of the model? They didn't know that. No one explained that to them. I looked it up and found out that stuff from reading some stuff about the models I happened to read about, and I happened to run into somebody in the reopening committee that's a friend. Okay, so that tells you some of the reasons why it's kind of important to do the research and have these conversations.
Well, well, go ahead. I'm sorry. Did I cut you off?
No, but I want to let Jimmy talk some because I keep talking too much. And
well, I was going to ask Jimmy. Jimmy, you can respond to that, but as you respond, also answer this question here somewhere. How do you feel when you started looking at the data and posting it versus now? Is your stress level the same, worse? Is it what you expected? And then you can also respond. And don't giggle when I ask you a very good question, sir. Damn it.
Well, I'm giggling because, and people who have seen me analyze data will confirm this. I don't really get much of a reaction in either direction. Right? I like the data is the data, and I don't get overly bent one way or the other. So I'm no more stressed now than I was. I am concerned. I think there's a lot of things that we need to address and we need to do differently and better as a society. I think this is an example of I'm going to say a pretty poorly handled situation. And I could probably be stronger than that if I was pushed.
You know, the expression for that in the Navy, Jimmy, was a Charlie Foxtrot.
Yeah. And yeah, it's been just really, really poorly done. Most of my frustration is with how poorly we have responded as a country and as a state, and how we can't even have a conversation about it.
But unfortunately, it seems to me, my simple brain kind of kicks in. If we put plans in place to protect the elderly and those that have compromised immune systems, and put things like that in place, policies and procedures, give people permission to raise their hand saying, I'm one of those compromised folks, and then let other people kind of go about things and trust that they'll use some common sense. I would like to think stuff like that would work. But I'm also, not the smartest guy in the room or on this video. So,
well, I don't know about that, but you're right that we've got to find some other place to be. Like, this is not the place to be. This is not the answer, and completely opening up is not the answer either.
Yeah, we can't hang out in the middle.
And that's the problem. So, like, when Eric's talking about these lawmakers who don't have this information, I find that incredibly frustrating. I have a Facebook page. Come talk to me. I can read this stuff. I can tell you what the answers are. And I bet if you looked around a little bit, you could find, an epidemiologist who might even be better at it than me. And this is a push on politicians. I think politicians really, really struggle with this. I'll give you an example. Joe Biden last week said, we should train police to shoot people in the leg. All he had to do was ask somebody in the security detail if that was a good idea or not, but he didn't, right? He went out and made this suggestion, and it was, he's walked it back now, thank goodness, but it just didn't make any sense because he didn't talk to the right people. So the politicians have access to the right people. They need to talk to the right people. They need to be able to listen to them.
The problem with that is, and then I'll bring up my last point here, or my last two real quick. The problem with that is a lot of politicians, unfortunately, seek out the opinions that best suit them getting reelected, or they'll seek out the opinions a lot of times that fit their constituents. Or to be honest with you, that may not even, I know a lot of friends that are in politics. They could just be getting the wrong information and be trusting like we are. It doesn't have to be evil or deviance or malice on their part. It could just be they've got a trusted group of people that have always done them right. They hear this, they move forward, because what did we say? Make a decision. Well, they make a decision and it's based off faulty info, and now you can't walk back decisions like that.
So one of my favorite expressions is never blame on evil intent what you can explain by incompetence. And so a lot of what's happening now is a lot of people are saying, well, our government, did they do this on purpose? Are we in some kind of a giant conspiracy movie, pre-apocalyptic disaster that's being caused by, puppet masters, whatever those theories are. My simple thing is, well, we explain it better by incompetence. And I think part of the incompetence is, it's not even that these people are not smart or they're not trying. It's that there's so much information going around. There's so much information that you have to parse through. I will put some blame on our media that they're not doing the job that Jimmy and I have done to actually parse through the numbers. Where are the investigative reporters anymore? There's a recent book that came out that somebody's raised some of these same kind of questions. There's that kind of pushback. There's also kind of been, I think, some pushback about the narrative being controlled by left-leaning or right-leaning, depending which side it was. The media outlets didn't want to put out stuff that was the information that would be useful. You have to really dig for it. I think Jimmy and I both realized you had to find the article that discussed the topic and then find the links or whatever that were being referenced, and then go actually read those and do the kind of work that way back in when we were kids, Woodward and Bernstein would have done for us. So all we have to do is read the book and trust them.
But I'll say this. I think some of that is just the way the systems are, and all. But some of it I think can be intentional. I do a podcast weekly with a lady that has a podcast called The Propaganda Report. And I'm learning that a lot of times stuff is buried inside layers of other stuff, because really I can personally make more money if I'm the only one that knows the good data and I feed you what I want you to have. And that's on both sides, depending on, what era we're in. I'm not here to piss off Jimmy at the very end when we've done so good so far. Hey, I want to say this, and I got one question for Jimmy. Here's the other thing that I want to bring up. False positive tests. We talked about that. There's tests out there that they first started that were given, bad results. The CDC there was an article out that they were conflating the data between the viral test and antibodies test. You remember that headline that came out? Then we see this week where she said from the WHO, it's rarely spread through people who are asymptomatic, and she walked it back. Wear a mask, don't wear a mask. Jimmy, do you wear a mask, sir, when you go out?
I do.
Me too. Thank you. And I do that because there's other people. I don't do it in my car when I'm by myself. I don't do it when I'm walking on the track. But if I'm in the grocery store, damn it, I'm wearing a mask. And if you don't want to, you don't have to.
So can I just comment on that real quick, Clint?
You can. Yeah, go ahead.
Yeah, the lady from the World Health Organization had one of the best walkbacks. So she came out and said, what was the actual quote? Highly unlikely or very unlikely that it's
extremely rare.
Extremely rare. That's the word I'm looking for people who are asymptomatic. And then when she was come back the next day for another news conference, they asked her, she's trying to clarify and said, well, I'm not suggesting we change any policies or people stop wearing masks. I was just trying to tell you what we know.
Yeah, it could be 40%. The modeling says that it could be up to 40%.
She didn't walk back the actual statement, but she walked back the ways people were supposed to interpret it by trying to emphasize something else. And it was just, what is going on here, folks? There's somebody. You guys got to learn to communicate better if you want the public to trust you, I think.
Well, we do live in that word. We do live in a society where everybody wants to sue everybody. So everybody's afraid that if they say the wrong thing, that they're going to be held accountable. And this is the most important question, though, real quick. I know, saying that to an attorney, I'm about to
immunity bills to give businesses immunity for anything related to the epidemic is another topic for another day.
So do me a favor, real quick. You just said say that again because I cut you off. That was my fault.
So another topic for another day is governments are in order to get businesses to reopen, they are passing laws that basically say businesses, people out in the community cannot be sued for things related to the emergency, so that will encourage people to reopen. The big fight is going on in some states is A, whether you need a law like that, and B, how broad is the immunity? And I tell you guys from firsthand knowledge that it's right now being considered in the Tennessee legislature, and the fight is how broad is the immunity going to be? That's a whole different topic for a different day, but it's the reality of our world that's the kind of stuff that they're saddling us with on top of all the other stuff.
Litigious is the word I was looking for. I'm just proud that I remembered it before we left. And so, Jimmy, here's the question I have for you. And so people will watch this over the next couple of weeks. And if we need to do an update, Eric, I'll be happy to do that. I love the conversation. Jimmy, this is the biggest question I have because your expertise, other than being a data and a scientist on that end, you're a GPS guy as far as, the tracking systems. Number one, is 5G going to be horrible for us? Is it going to be the same, worse, better?
No difference, except you're going to get more data.
Thank you very much, sir. Second is nobody else is listening, just me and you, Jimmy.
Okay.
Are they really tracking everything we do?
Yes.
Damn you. Dadgummit.
Like in ways that you cannot begin to imagine.
Would you wait a minute. No, wait, I was supposed to end this with a funny little thing, and you throw that in there?
I thought we're ending it with a funny thing.
No, that's not funny. That makes me not sleep tonight. Dadgummit. I got to take another
look at some COVID-19 data.
A whole nother program, Timmy, and Clint and I are both going to ask you tough questions for 2 hours.
I'm telling you right now, if you're telling me they're tracking me in ways I don't know, and I've got a paranoid ADHD mind, you, sir, are going to have a private conversation with me.
Those websites that you like, it's too late, but you need to stop visiting them.
I'll take you to mind your own affairs, sir. All right. Hey, I'll just say this. I appreciate both of your times. I know this was a longer conversation than I normally have. First time we've done this, us three together. So the time and the patience is appreciated. Jimmy, is there anything you want to say about this before we head out? Is there any final thoughts on this whole thing?
No, just keep watching the numbers, see what it does, and, make good decisions.
Eric, you want to say anything?
I just want to say thank you, Jimmy, for doing this. It's fun. You and I are not going to agree on stuff politically over time, but I think we've known each other long enough and can base our conversation on facts and understanding and do it politely. I enjoyed the heck out of this. This was a good talk.
It was a good talk. Thank you, Eric.
Thank you both. I appreciate it. We'll say bye to everybody. Go check out Jimmy's post and go check out Eric's stuff. Both of them do it thoughtfully, and I stalk them both now in the middle of the night. And Eric, those are the sites that I'm on, sir. I'll thank you to disparage my good reputation, sir. Y'all have a good night. Bye, everybody.
Bye.
Bye.